Hello everyone, welcome back to another overview of structure and function in anatomy. This time we're going to be covering the knee joint, including the tibiofemoral and the patellofemoral joints. So gather your lecture outlines, PowerPoint slides, you might want the trail guide, maybe you want to grab the kinesiology textbook by Newman and just get everything ready to go and we'll get started. We will begin with the tibiofemoral joint, and the bony elements, of course, the distal end of the femur is the convex portion, so we have the medial and lateral femoral condyles, and they articulate with the proximal end of the tibia, which is concave. This is a modified hinge joint, so it certainly moves in the sagittal plane with flexion and extension, but it also has tibial rotation. So you may recall that the tibia has an automatic rotational component during knee extension. So we'll review that in a minute. To enhance or to deepen the articulation and to stabilize the joint, we have two intra-articular discs in the knee. We call them the medial and the lateral meniscus in particular. And we can see that better here from the top. And the meniscus pretty much follow the shape of the condyles. So the medial meniscus, remember, is more oval, and that mirrors the more oval shape, the larger and more oval shape of the medial femoral and tibial condyles. The lateral meniscus is more of a C-shaped, a little more round, and it, of course, mirrors the rounder shape of the lateral femoral and tibial condyles. The medial meniscus is tied in with the joint capsule as well as the medial collateral ligament. So again, it helps to improve and contribute to the stability, particularly on the medial aspect of the knee. We can see a couple of ligaments here. We can see part of the anterior and posterior cruciate ligaments. You can see another view of them here. So these, of course, remember, are named for their attachment on the tibia. So the anterior cruciate ligament is attaching more anteriorly. It courses superiorly and laterally and posteriorly, and attaches on the medial aspect of the lateral femoral condyle. And then the posterior cruciate ligament, remember, what does cruciate mean? Right, it means cross. So you can see, here's the cross. The posterior cruciate ligament arising from the posterior aspect of the tibia, that intra-articular eminence. It's going to come up anteriorly, medially, and superiorly, and it's going to attach on the lateral aspect of the medial femoral condyle. So these two cross, and we're going to be doing some special tests in class to assess the integrity of both the anterior and the posterior cruciate ligament. One of the things that the anterior cruciate ligament limits is the tibia translating or sliding forward, and the posterior cruciate ligament limits the tibia sliding or translating backward. And then when we look at injury or damage to those ligaments, we'll look at other mechanisms or other motions that would stress the ligament. On the lateral side, of course, we can see the lateral collateral ligament. And I think if we go back, nope, well, that's a nice view of the cruciates though. We can see the anterior and posterior cruciate ligament in that view as well. We can see the lateral and then the medial collateral ligaments here. Remember, the other names for those, for the lateral one would be the fibular collateral ligament, and the medial could also be called the tibial collateral ligament. So the tibial collateral ligament or medial collateral ligament is fused in or part of the joint capsule on the medial side, again, as well as the medial meniscus. So it's considered a capsular ligament. The lateral collateral ligament is apart from the tibiofemoral joint capsule, and so it's an extracapsular ligament. The lateral collateral ligament would be stressed with a varus stress, and the medial collateral ligament would be stressed with a valgus stress. They both provide medial lateral stability to the knee. And then posteriorly, part of the posterior joint capsule, we can see in this view the oblique popliteal ligament, and there's also an arcuate ligament, which I don't believe is pictured here, that contributes to posterior stability of the knee joint. Remember that the closed packed position of the knee is extension, so all the ligaments in the joint capsule are most tight when the knee is in full extension. That wraps up the review of the structure. Let's look a little bit at the muscles and the muscle function. And pretty straightforward. We've got the quadriceps on the front and the hamstrings on the back. I really like these sagittal view or these cutaway or horizontal plane views or cutaway views because they give you a really nice sense of the geography of all the muscle belly groups in relationship to one another. So we think about, of course, the quadriceps on the front, and we've got 4 of those, of course, the rectus femoris, and then deep to that is the vastus intermedius muscle, and then of course the vastus lateralis, a big bulky one laterally, and the vastus medialis, and we'll look at a couple of orientations of that. All those muscles, as bulky as that is, they all kind of wrap around and attach, along the linea aspera on the posterior side. So if you take your hand and you try to move your quads around, you're going to find you have a lot of mobility. You can move your quadriceps as a group a lot medially and laterally because a lot of that attachment is all in the back. The only member of that group, of course, that crosses the hip is the rectus femoris, coming off the AIIS, and coming down, and of course all the muscles of the quadriceps blend into a common tendon that encapsulates the patella and then comes down to attach to the patellar tendon. I'm sorry, to the, you know what I'm trying to say, this little bone right here, tibial tuberosity, right. So via the patellar tendon or the patellar ligament. The most technically correct term is the patellar ligament because it connects the patella to the tibial tuberosity, but it's very common usage or terminology to call it the patellar tendon, so that's perfectly fine. This as a group is called the extensor mechanism of the knee. And so of course tension's created and it produces knee extension. The different fibers of the quadriceps do go in different directions, and they can have a pull on the patella, and we'll be looking at that particularly when we look at patellofemoral syndrome, and we will look at it a little bit in just a minute when we look at the function of the patellofemoral joint. But you can see here a nice view of the vastus medialis, and some of those fibers are really horizontally oriented, so they're considered the vastus medialis oblique, or VMO, and some are more longitudinally oriented, so vastus medialis longissimus. And so there's a lot of focus put on the VMO because it creates the medial pull to balance out the pretty strong lateral pull of the quadriceps on the patella. Innervated by the femoral nerve, and I think that's about it for the quadriceps. The hamstrings posteriorly, of course, they show the common tendon proximally on the ischial tuberosity. 3 muscles to the hamstrings, semimembranosus, semitendinosus, and then the biceps femoris. All innervated by the sciatic nerve. They all produce hip extension and knee flexion, and then of course the biceps femoris is lateral, so it can, if the knee is flexed, it would produce tibial rotation laterally. Semimembranosus and tendinosus are on the medial side, and if the knee again was flexed, it could produce tibial rotation at the medial side. I didn't really mention, back when we were looking at the quadriceps, at the final portion of knee extension with a little bit of overall lateral pull, that is when the tibia does externally rotate. We call that the screw-home mechanism of the knee. And again, if we go back and look at our condyles, since that medial condyle is longer and more oval-shaped, articulation has to continue on the medial side, and it kind of pivots on the lateral side. So it gives us that about 20 to 30 degrees of external tibial rotation as the knee is completing extension. So that again contributes to the stability of the knee. All right, well that is pretty much the review of the tibiofemoral joint that I wanted to do. So let's go on to the patellofemoral joint, and you get a nice anterior and posterior view of the patella, and you can see it's got kind of this little groove here, and that divot or groove you can see reflected here from this more inferior superior view. And you can see how that patella kind of sits into the groove on the femur. Just always reminds me of a diamond sitting, you know, on top of a diamond ring. And this really needs to sit in here correctly. And a lot of the patellofemoral disorders we're going to look at are because the patella is no longer sitting squarely within the within the femoral groove that it needs to be sitting in on the femur. So this is a gliding joint, so there's no rotational motion. The patella glides superiorly during knee extension. It glides inferiorly during knee flexion. It also has, during knee extension, it glides a little bit laterally as well. And that's because of the overall pull of the quadriceps. So here are those force vectors with the different, related to the different elements of the quadriceps. So here's vastus intermedius coming up here, and the rectus femoris. We've got vastus medialis, remember, has the two components, the longest portion coming fairly straight up. The vastus medialis, much more of a horizontal and medial orientation. So the vastus medialis in general is really responsible for providing that medial balance. Vastus lateralis, of course, is going to pull a little bit laterally. So this big red line is the summation of all the torques of the quads, and this represents the overall line of pull of the quadriceps. And so it's also the Q angle, and you had to measure the Q angle back in kinesiology. And so you might remember you put the goniometer, you centered it in the patella, one arm went down to the tibial tuberosity, and the other arm came up and went toward the ASIS. And so the Q angle was again the degree of lateral pull of the quadriceps. That overall pull, that lateral pull, has to get balanced by this medial pull, and so we're going to be looking a lot at that. Normal Q angle is about 15 degrees. It's a little bit bigger in men or women, a little bit less in men. The other thing that's really important to think about with the patellofemoral joint is joint reaction force. And hopefully you're getting very comfortable with that term now. I hope it doesn't make your eyes cross and your teeth chatter when you hear it, but joint reaction force is the amount of force between the two bony components of the joint. And we know that if joint reaction force is excessively high, or high for a prolonged period of time, that it can cause accelerated wear and tear on the joint surfaces. So we definitely want to educate patients in ways to minimize their joint reaction force in general, but particularly with people who are coming to us with pathology. So when we look at the patellofemoral joint, there's really very little joint reaction force when you're extending an open chain, because as the knee comes toward extension, the patella is pretty much gliding horizontally right on top and parallel to the femur. So there's very little compression between the patella and the femur. In contrast, when we are loaded or in closed chain, and then we're going into knee flexion, we've got a couple of things happening. One is that with flexion, remember, the patella gets pulled inferiorly, so it's coming down from kind of this top part on the femur down to this more rounded part of the condyle. In addition, of course, the quadriceps are active, and so they are working very hard to keep the patella, to control the knee, and it also pulls the patella against the femur. So this black line here is the overall joint reaction force. So what you're seeing here is that when the person does a very partial squat, a minimal squat, the quadriceps don't have to pull that hard, and so the joint reaction force isn't quite so bad. The deeper we go into the squat, the harder the quadriceps work, the more tension you see, the further down the patella is pulled. That increases by quite a bit the joint reaction force. And so if you look at, again, just a really deep knee bend, 130 degrees or so, almost full knee flexion, the force there is going to be about 8 times body weight. So that's in contrast to when we're just ambulating. So again, the initial contact, it's still closed chain, but the knee, remember, goes to about 10 to 15 degrees of flexion. joint reaction force there is only half of body weight. And then kind of in between there, if we look at stair climbing, joint reaction force with the knee at about 60 degrees to climb the stairs is about 3 times body weight. So the more we have the knee flexion with eccentric activation of the quadriceps or isometric activation of the quadriceps, pulls the patella against the femur and more forcefully, and so the joint reaction force is going to go up higher and higher. And we'll be talking a lot more about the implications of that once we get to patellofemoral disorders. So that's the end of the overview. I hope that you found this helpful. If there were areas that kind of sounded a little bit fuzzy, then that's a good clue to you that you need to go to your kinesiology book, your kinesiology notes, review that. Definitely want to review attachments and actions, look over your innervations so that you're really comfortable and you're ready to come in and work on exercises. So I will see you in class.